Good afternoon. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, welcome you to today's special webinar. Today's topic, Social Determinants of Health Student Research Forum, What is the Impact on Dentistry?, is provided by a statewide program called Texas Recruits and Retrains, TRR for short, that partners 3 dental schools in Texas to address dental workforce issues. TRR provides public health training and research opportunities aimed at improving access to care. This webinar will describe 4 summer research projects on social determinants on health and their impact on the practice of dentistry today and in the future. TRR worked in collaboration with the CareQuest Institute for Oral Health. Today's reactors are Elaine Benton, Dr. Joe Simmons, Dr. Kieran Burdett, and Dr. Carl Vesey, all from Texas A&M College of Dentistry. The Texas Oral Health Coalition is pleased to host and provide free continuing dental education credit for submitting the completed online evaluation by November 11th, which is 2 weeks from today. The evaluation link and course completion code will be provided at the end of today's presentation, and we'll also put this information in the chat box for you towards the end of the presentation. If you should have any questions regarding the evaluation process or need assistance, please don't hesitate to contact us at info@texsoc.org. There will be time for Q&A at the end of today's presentation. Today's facilitator is Dr. Madhuli Semtani, who is a foreign-trained dentist and serves as a biostatistician in the Analytics and Evaluation team at the CareQuest Institute for Oral Health. I'm pleased to now turn this over to Dr. Semtani to introduce today's presenters. Dr. Semtani?
Thanks so much, Beth. CareQuest Institute for Oral Health worked in conjunction with exceptional students at Texas A&M University to examine and understand the impact of social determinants of health on practice of dentistry and oral health outcomes. We all know oral health disparities, like all health disparities, are outcomes of upstream social factors, such as unfair differences in wealth and education, social status, and culture-related perspectives and conventions. Oral diseases like dental caries, periodontal disease, and oral cancer, issues such as poor access to dental care, and low oral health literacy levels are social, political, behavioral, and medical in nature. These conditions will only be controlled by the promotion of initiatives that prioritize the improvement in the social determinants of health as a backbone structure for development of healthy enabling environments. Understanding the impacts of social determinants of health can begin to prepare oral health providers to identify and address health disparities and to promote overall health equity. I am excited by the new knowledge we'll gain today and how it will inform the ways in which we continue to improve the oral health for all. Before we dive in, I have the distinct pleasure to introduce our speakers. Our first speaker is Reem Al-Siyar, who is a first-year dental student, and she will be presenting on distribution of federally qualified health centers by location type, urban versus rural, and access to transportation services in North Texas. This topic is especially important since rural residents are more likely to experience some of the contributing social factors that impact health, such as poverty. The impact of these challenges can be compounded by barriers already present in rural areas, such as limited public transportation options and fewer choices to acquire healthy food. Our second speaker is Asma Hussain, a second-year dental student, highlighting the impact of COVID-19 on dental burnout and its correlation to social determinants of health. Dental burnout is extremely understudied, but a very important topic. Past medical research shows that addressing patients' social needs may significantly reduce physician burnout. We need to expand this literature to include dental burnout. Next up is Michaela Medrano, who is a first-year dental student, and she will be presenting on the impact of social inequities on dental fear. Dental fear leads to delayed care utilization and eventually poor oral health outcomes. This presentation will help us understand the link between social factors and dental fear. And last but not the least, Lauren Soto Ramos, a first-year dental student, will be presenting on the association between social determinants of health and tooth loss due to caries or gum loss. This presentation further highlights how unaddressed social factors can lead to poor oral health outcomes. After our speakers present what is sure to be compelling evidence and analysis, we'll all join the discussion and engage in a Q&A session. So please join me in welcoming all our presenters today, and let me turn it over to Reem for our first presentation. Reem.
Hello, thank you so much, Dr. Santani. Hello, everyone. My name is Reem Alsiad, and this past summer, I worked alongside Dr. Aneta Batuni to study the distribution and characteristics of federally qualified health centers and access to transportation services in North Texas. Next slide, please. So according to HRSA, a federally qualified health center, also known as an FQHC, is one that provides primary care services in underserved areas. And while reading our literature reviews, we realized that there are a lot of barriers to accessing care, such as financial constraints, limited healthcare supplies, the lack of quality healthcare and communication, and transportation difficulties. All of these prevent individuals from receiving the proper medical and dental care. So we decided to focus on transportation barriers because evidence supports that transportation difficulties lead to poor health outcomes due to their missed appointments. Next slide, please. So for the purpose of our research, we decided to conduct our study on the state of Texas, specifically North Texas. And this is because Texas has the highest percent of people without health insurance, which is 18.4%, as seen from this bar graph. Next slide, please. So the aim of our study is to describe the distribution and characteristics of the federally qualified health centers in the North Texas area. We also wanted to identify the transportation services available to patients when visiting these FQHCs in North Texas. So as you see here on the red Texas, the pink area is where we conducted our study, which is North Texas. And then to the left of that, there's the distribution of federally qualified health centers, and each red point marks that of an FQHC. So if you could please play that. So that's Texas. And then this would be zoomed up into North Texas. And then this is going to be the Wichita area, which is a part of North Texas. And then the Dallas metropolitan area, which is also part of North Texas. Next slide, please. So from our literature reviews, we realized that individuals are less likely to access their needed services when the appropriate clinics are not available and when they face transportation difficulties. Many individuals actually depend on public transportation. But of course, with that comes lengthy transit routes and multiple transfers. And so these people are at an increased risk of foregoing needed services. Therefore, if the appropriate number of clinics and transportation services are available to these clinics, we may alleviate some of this access to care issue. And as a result, we may have the prevention of diseases to the entire population, the detection of health issues early on, and aiding in prolonging life. Next slide, please. So once we have decided what our topic was going to be about, we identified the counties and cities within those counties in the North Texas area. We also marked down whether that county was classified as a more urban or a more rural county. And a county that has more than 2,500 people is considered urban, and one that's less than 2,500 people was considered rural. So after this, we also located the federally qualified health centers in North Texas. And for the purpose of this study, an FQHC residing in an urban county was considered to be urban and vice versa. We also created a set of 5 questions to be answered by each FQHC, which are represented in this gray table. Once all of our information was collected, we ran descriptive and inferential statistics in order to gather our results. Next slide, please. So our results are separated into 3 sections, which are the location and characteristics, types of professional services, and types of transportation services. So we're going to be starting off with the location and characteristics. So if you take a look at the pie chart, it's divided between urban and rural. Urban is in blue and rural is in red. And this is going to be the same for the remainder of the graphs. So if you do look at this pie chart, out of the total 30 counties, 16 of them are rural. And on the other hand, the remaining 14 out of the 30 total counties are urban counties. So when looking at the rural counties, only 2 out of the 16 provide at least one federally qualified health center. This is different than the urban area, which shows that 8 out of the 14 urban areas provide at least one FQHC. So the bar graph to the right shows a little more specific representation than that of the pie chart because it represents the number of FQHCs per county. Next slide, please. So this table represents that we were able to find an association between having at least one federally qualified health center and the location, whether that be urban or rural. Next slide, please. We also looked into the funding and hours of operation of, can you return one, please? Yeah, we also looked into the funding and hours of operation of each FQHC. The main takeaway of these two bar graphs is that the FQHCs are mainly federally funded, and they do operate during normal business hours, which is from 8 a.m. to 5 p.m. Monday through Friday. Next slide, please. So if we take a look at this bar graph, we can see the top 5 most common types of professional services offered. All the FQHCs provide medical services, so this is not shown on the graph. Here you can see that the most offered service was that of pediatrics and women's health. And this is because out of the 45 total FQHCs, 38 of them offer pediatrics and women's health. And out of these 38, 3 of them resided in rural areas, and the remaining 35 are located in urban areas. And then the least offered service was that of dietary. And this is because only 13 out of the 45 FQHCs offered dietary services, all of which were located in urban areas. And as for dental, we can see that only 18 out of the 45 total FQHCs offered dental services, with 17 of them located in urban areas and only 1 FQHC providing dental services in rural areas. However, we were not able to find an association between the location and types of professional services offered. Next slide, please. So onto our last set of results, which is the transportation services, we wanted to test if there was a difference between the public transit and free transportation services provided by the FQHC. We also tested to see if there were both or none of these services offered. So the main takeaway of the first bar graph to the left is that all of these FQHCs provided some type of transportation service, except 2 of them, and those 2 were located in urban areas. Also, the most common type of transportation is that of public transportation. So we decided to break this down, which is seen by the bar graph to the right. As you can see, the most common public transportation is that of bus only. Again, we were not able to find an association between the location of the FQHC and the availability of the transportation services. Next slide, please. So some of the conclusions that we gathered from our research is that all of the clinics, except for 2 urban clinics, offered some type of transportation service. We also were able to find an association between the location and having at least 1 federally qualified health center. Also, as with any research project, we were met with some limitations and some strengths. For us, our strengths were that this idea has not been studied before, especially in North Texas. We also created well-defined research questions and structured and clear methods. Some of the limitations that we were met with is that we had a small sample size. Yes, we did have 45 FQHCs. However, 40 of them were urban and the remaining 5 were rural. So because we only had 5 rural FQHCs, we were not able to run certain associations that we wanted to. And another weakness that we encountered was some reporting bias. And this is because whenever I would call, most of the time I would be transferred multiple times. And in the end, I don't really know who I spoke to and if they gave me the correct information. Next slide, please. So in order to better our results in the future, one thing that would be beneficial would be to expand our area of interest to include more FQHCs, specifically that of the rural FQHCs. We would also like to test to see if there's an association between the location and the type of transportation service. And one recommendation we suggest is to increase advocacy and funding for a greater number of FQHCs, especially in rural areas. And with this, it would be beneficial to improve the transportation services. Next slide, please. I would like to thank my mentor, Dr. Annetta Batuni, for guiding me throughout this research project. I have learned so much under her wing. I also want to thank Dr. Raghad Obidad for helping us run our association tests. And I want to thank Tristan Levkamp, Texas A&M College of Dentistry, and the Public Health Department. I also want to thank you all for listening to my research project. I really appreciate it. Next slide, please. And here are my references. And then one more slide is also my references. So for now, I would like to introduce our next speaker, Asma Hussain.
Thanks, Reem. So my name is Asma Hussain, as Reem said, and I worked with Dr. Timothy to answer the question, is your dentist experiencing burnout? Next slide, please. So let's start with some background on what burnout is. So burnout is defined by the American Dental Association as a condition experienced by workers and other healthcare professionals in which they develop depression-like symptoms as a result of aspects of their role. So this includes physical, mental, and/or emotional exhaustion. And some examples of other signs are headaches, fatigue, and anxiety. Next slide, please. So there's not a lot of current literature on burnout at the time that I conducted this research over the summer, but there is some literature just describing what burnout is and what it means. 1 second. So there is some literature defining what burnout is and the signs and symptoms of it. And there is a study that was conducted in Turkey that found that there was an increase in burnout among dentists who worked through the pandemic. But there, again, at the time of the study was no literature really about the effects of this pandemic on burnout and nothing about the specific impacts based on different populations of dentists. Next slide, please. So our research question then was, what is the impact of COVID-19 on dental burnout? And does burnout affect the social determinants of health? Next slide, please. So our data was collected from quarterly surveys conducted by CareQuest Institute for Oral Health. They assembled a research panel, and the survey was sent to 22,075 providers that were enrolled in DentaQuest. Of those, only those that were, of those that responded, only those that were 18 plus were very familiar with their dental office's patient volume, staffing, insurance carriers, finances, etc. were eligible to participate. And the data that we used was collected from the first of the 4 quarterly surveys, and it was collected between March 9th and April 2nd, 2021. And 4 reminders were provided before they ended accepting responses. Next slide, please. So there were 2 specific questions that were asked about burnout on the survey. The first one was, how often do they feel burned out from work? And the second question was, have your feelings of burnout increased since the COVID-19 pandemic began? And for the first question, there were 7 different answer choices that we collapsed into 2 different groups for analysis. The first group was the frequently group, and under that category fell every day, a few times a day, and once a week. And then the second group was the infrequently group, and under that was few times a month, once a month or less, few times a year, and never. And then for the second question, the answer choices were just yes or no. Next slide, please. So there were 58 questions total that were in the survey. They were all multiple choice, and there were sections on the impact of COVID-19 on practice, telehealth, alternative payment models, value-based care and integrated care, provider and practice profile, and office information. Next slide, please. So there were 575 providers that agreed to participate and were eligible, but 377 actually responded, which left us with a participation rate of 66%. 71% of dentists said their feelings of burnout have increased since the start of the pandemic. And we found that the 45 to 54 age group experienced the greatest increase in burnout at 53%. And now we'll go further into the breakdown of differences based on gender, race, and location, and years in practice for burnout. Next slide, please. So now, when looking at gender, we found that there was an increase in burnout by gender for females. 65.8% of females said that they do experience burnout frequently versus 49.6% of males. Next slide, please. And that since the start of COVID-19, 73.4% of female dentists said that they did experience an increase in burnout versus 65.9% of male dentists. Next slide, please. Next up is burnout by race since COVID-19. We found that Hispanic dentists deal with the largest amount of burnout, followed by Caucasian, Asian American, Indian, Hawaiian, Pacific Islander, which are all one group, and then African American dentists. But the big takeaway here was the sample size limitation, which we do think impacted our responses and our findings. Next slide, please.
So she says next, I have to press what?
So when looking at burnout by location, since COVID-19, we found that rural dentists did experience the greatest increase in burnout since COVID-19 at 72% versus suburban and urban dentists experiencing less burnout. They reported only 56% reported that they experienced burnout frequently. Next slide, please. Next slide, please. And now, lastly, looking at burnout by years in practice since the start of COVID-19, we found that dental healthcare providers that have been in practice for less than 20 years experienced the greatest increase at burnout at about 65 and 66% versus 48% of dentists that have been in practice for over 20 years experiencing an increase in burnout. Next slide, please. Now, when looking at the limitations of our work, the biggest thing was the sample size limitation. Only 575 dentists responded and 377 dentists participated in the survey, which isn't a ton when you look at the whole population of dentists in the US. And also there wasn't equal participation by rate. So we definitely believe that if we were to have a greater number of participants and a more inclusive sample as well, that our results would definitely be affected. And also there is a participant bias because the study only included providers that were part of DentaQuest, not just all dental providers. And also just the timing of the survey in reference to COVID-19 at the time of the survey, this was about 6 months ago. So we do believe that there could be an impact in the results if we were to conduct the same survey and analyze the results now. Next slide, please. So what would we change if we were to repeat this study? Well, the biggest thing, which I just mentioned, was to increase the sample size, also not limit the survey to those that are part of DentaQuest, ask more specific questions on burnout. As I mentioned, the survey that we used only had a couple questions on burnout. So it'd be great to use some more targeted questions on burnout and have a couple more of them. So using something like the Maslach burnout inventory would be a great thing to use for next time, because it assesses emotional exhaustion, depersonalization, and personal accomplishment, which are all tied to feelings of burnout. So we could get a more greater understanding on burnout since the start of the pandemic. Next slide, please. And now lastly, the public health implications. So the reason that burnout is so important is because quality of care will be affected. Some symptoms of burnout are feeling demotivated, depersonalization, poor concentration, and reduced sense of accomplishment. And when a dentist is experiencing these symptoms on a daily basis, something is going to slip through the cracks. It will manifest, and these symptoms will start to show through, and eventually the quality of care will be affected. There are a couple of studies that suggest that depersonalization, emotional exhaustion, MBI scores for physicians are related to patient care outcomes. So we would think that the same would hold true for dentists. Next slide, please. Now, in conclusion, dentists have been facing many challenges since the start of COVID-19, such as the fear of getting COVID, financial stress, and uncertainty, collectively causing them to feel an increase in burnout. Next slide, please. And a big thank you to Dr. Timothy, Dr. Ruest, and the CareQuest Institute for Oral Health, with whom this research would not have been possible without. Thank you, everyone. And next up, I'd like to present Michaela Medrano.
Hi, my name is Michaela Medrano, and today I will be talking about the understanding and addressing of dental fear. I worked alongside Dr. Shirley Lewis, and again, we were talking about dental fear. Next slide, please. So what is dental fear? Dental fear is widely experienced from adults to children in a dental setting, and it can lead to avoidance of dental visits and more. So in the image, you can see that dental fear can cause a delay in visiting the dentist due to that fear, which can then cause dental problems and lead to symptom-driven treatment. And that can be more extensive treatment, further creating that dental fear, and the cycle continues. Next slide, please. And so social determinants of health are basically factors in which make up our lives. And inequalities in these factors, such as access to education, income, can prevent health equity. And health equity is basically allowing the person to live their best possible life. And so we are proposing that dental fear has a play in this prevention of health equity, specifically in accessing dental care. Next slide, please. And so our research topic is basically to determine dental fear trends related to social determinants of health and discuss the available treatment modalities. Next slide, please. And so what we did is CareQuest Institute for Oral Health provided a study, and the study was called The State of Oral Health Equity in America. This study was conducted in 2021, and they used a nationally representative study. And the survey asked how patients' dental visits went. And today we are looking at the response rate for those who confirmed that their nervousness made the treatment difficult or unsuccessful. Next slide, please. So alongside this CareQuest study, we also conducted a separate literature review using various search engines to look for studies and reviews that discuss dental fear, trends, and treatment modalities. The findings from the CareQuest study and literature review were then compared. And then the literature review findings for treatment modalities was looked at and determined to see what treatment modalities are available. Next slide, please. So some of the factors that we looked at and dental fear trends are age, gender, income, education, employment, and race. So dental fear trends were observed from both the CareQuest aspect and also the literature review. The literature review also looked at past experiences mental health, and sexual orientation, factors in which the CareQuest study did not provide. Next slide, please. And so the dental fear trends that were confirmed with the CareQuest study and the literature review was that people who are younger, females, those that identify with a lower income, have a negative past experience, and poor mental health have a higher level of dental fear. And inconclusive findings was found for those who have different race and ethnicity, education, and employment. So the CareQuest findings and the literature review did not provide the same findings. So we were unable to determine that there was a positive dental fear trend for these factors. And in the graphs below, you can see that those in the higher age group have a lower response rate, that their treatment was unsuccessful or difficult. And you can also see the same for females in the middle graph. And then lastly, for those who identify with a higher level of income. Next slide, please. And so after we compared the findings with the CareQuest data and the literature review, we were looking at the dental fear treatment modalities. So some commonly used treatment modalities are cognitive behavioral therapy, and that can include music intervention, and it can also include exposure-based intervention. Another commonly used treatment modality is communication, and that can be where the dental provider communicates what the procedure is going to include. Other commonly used treatment modalities are hypnosis and drug intervention. Some uncommonly used treatment modalities include group therapy, and group therapy was proven to be effective both online and in person. Some other non-common treatment modalities include social media with educational videos. And lastly, computer-controlled local anesthetic delivery. As pictured below, the anesthetic would be delivered in this pen stylus form instead of a syringe, which may contribute to dental fear. Next slide, please. And so one of the other factors that was looked at in the literature review was sexual orientation. So it was found that there is a higher dental fear for those who identify in the LGBTQ community. And this dental fear is directly correlated to the fear of experiencing maltreatment and discrimination in the practice. So that can be from being called the improper name or pronoun, and also being asked questions that do not pertain to their treatment. And the treatment modality for sexual orientation would be education on the LGBTQ health needs and inequalities, and using proper pronouns and name usage. Next slide, please. And so in conclusion, social determinants of health does impact dental fear trends. And healthcare providers should utilize this study and confirm dental fear trends and treatment modalities. That way we can determine dental fear in our patients and properly treat that. Some strengths of the research was most dental fear trends were confirmed, and the CareQuest study did use nationally representative data. Some weaknesses were the inconclusive findings and comparing studies in the literature review. At times it was difficult to compare studies from different countries and how they use different techniques to study these fears. Next slide, please. And future direction. So we're proposing a public intervention, whether that be educational programs and trainings for the public and patients, and also the dental providers. In-office therapy options. That way the patient doesn't have to travel far in order to address their dental fear, and updated forms. That way a patient can be called by their proper pronoun and name preference, and also parent title for those who adopt. Next slide, please. And future direction for the research. We would like to conduct further research in order to determine if there is a dental fear trend related to race and ethnicity, education, and employment. Because again, the CareQuest findings and literature review did not give us enough data in order to establish that there was a conclusive dental fear trend with these factors. Also, we would like to further look into new dental fear trends, such as related to genetics, the COVID-19 pandemic, infection control, and financial burden. Next slide, please. And lastly, I would love to thank the Texas Recruits and Retains Grant for making this research possible this summer, the CareQuest Institute for Oral Health for providing the study, and my mentor, Dr. Shirley Lewis, for all her support and guidance, and Tristan Lovecamp. And lastly, I would like to thank the audience for tuning in and listening to my research topic today. Next slide, please. And these last two slides are my references. Next slide, please. And last but not least, I would like to welcome Lauren Sorto to talk about her topic today.
Hello everyone, my name is Lauren Sordo and I am a D1 at Texas A&M College of Dentistry. This summer I had the opportunity to conduct research with my mentor, Dr. Raghat Obidat, and we looked at the impact of different social determinants of health on tooth loss. Next slide, please. So I'd like to begin by asking you all, why do we have oral health inequity and disparity? Well, there's really not one answer to this question, but a multitude of factors. And in public health, what we're trying to do is look at those barriers and factors. But to introduce this concept, I'd like to talk about this image. On the upper left, you can see what happens when we give people equality. When we give them equality in healthcare, it doesn't help everyone. Some people can't overcome barriers because we're providing them with the same resources as other people who need less. But if we look in the center, that's what we call equity. And that is where you give people the resources that they actually need and that will actually benefit them. But what would be even better would be if we could remove those barriers altogether. And that's what we see in the last image. So what are these barriers that I'm talking about? They're called social determinants of health. Next slide, please. These are a couple of examples of social determinants of health. They include things like income, debt, safety, housing, hunger, access to healthy foods, dental insurance, and they're the factors that affect us every day, and they're in our environments that we live in and work. Next slide, please. So to begin the research, I conducted a literature review to see what has already been done. The first study here was conducted in Brazil, and this found that families with higher income had higher functioning dentition as opposed to families with lower income. The second study in the United States showed that states that had higher income inequality showed more levels of tooth loss than states with lower levels of income inequality. For the third study, we found that areas or municipalities that had higher levels of education and higher levels of income actually had less tooth loss than municipalities that had lower levels of education and lower levels of income. And this was measured by using MDHI, which is Municipality Human Development Index. Next slide, please. So the public health significance of this is that we now know that oral health does not only affect the oral cavity, but affects our overall health. So the World Health Organization is guiding us into a more integrative approach at looking at chronic disease prevention. Examples of things that are already being done is structural changes such as water fluoridation, sanitation facilities, and availability of affordable and healthy food. Therefore, more research has to be done in order to prioritize the factors that have the greatest impact on patients' oral health. Next slide, please. So the objective of our study was to describe and analyze tooth loss among US adults that are 18 years and older by comparing different social determinants of health. And we were interested in their impacts. Next slide, please. So for our outcome variable, we decided to go with tooth loss. This is a well-known marker. It's relatively new, but it's very accepted now. And this study by Howarth in 2018 confirmed that it is a good marker for health inequity. Next slide, please. Here are more reasons as to why we picked tooth loss. So the current literature shows that there is a direct impact of the social gradient on oral health outcomes, and that new ways of measuring health need to be created. And one of those is counting lost teeth. Tooth loss is a great marker because it is both general and individualized. So it's general in the sense that we can look at large groups of people and understand that their tooth loss is due to a complex interaction of biological and social factors. But it also helps us on an individual level, because if we look at an individual patient and we see that they have tooth loss, then we know that they are having oral health issues. However, the effects of different social determinants of health on that tooth loss needs further investigation to be understood. Next slide, please. The methods for our study are here on this slide, and we did a cross-sectional design. We used data from a survey called the SNOHI survey, the survey of National Oral Health Equity conducted in January of 2021, and it had 5,320 participants. The 6 social determinants of health that we looked at were racial and lifetime discrimination, food insecurity and housing instability, and also lack of transportation and dental insurance. The analysis was conducted by 2 different tests. One was bivariate analysis, and the other was the multivariable logistics regression model. And these were conducted for each of those 6 determinants that we mentioned. And they were all adjusted for confounding variables, such as income, education, and age, that could skew the data a different way. The adjusted odds ratios and the 95% confidence intervals were reported, and a p-value of less than 0.05 was considered significant for our study. Next slide, please. The demographics were a majority of people 60 plus years old, majority female, majority white, and also majority had a higher education of college or more. Next slide, please. These were the results. The reported tooth loss of the participants showed that there were 4 main social determinants that had significant differences. So what this means is that people who reported facing food insecurity had significantly higher levels of tooth loss than people who did not struggle with food insecurity. The same goes with lack of transportation. People who struggled with transportation had higher levels of tooth loss than people who did not struggle with that. As we would hope, the opposite was true for dental insurance. Those who did have dental insurance had less tooth loss than people who did not have dental insurance. And then for location, those who lived in non-metro areas had significantly more tooth loss than people who lived in metro areas. Next slide, please. So from those numbers, we were able to calculate these odds ratios. And what we can tell you is that people who face racial discrimination are 35% more likely to have a tooth extracted. When we look at food insecurity, that number goes up even higher, at 78% more likely to have a tooth extracted. For lack of transportation as well, 72% more likely to have a tooth extracted. And then for housing instability, they're 37% more likely to have a tooth extracted when compared to people who don't have housing instability. Next slide, please. So from those adjusted odds ratios, we were able to calculate the predicted probabilities of at least one tooth being extracted. What this means is that in the future, going forward, we can say that racial discrimination will show significant more tooth loss when compared to people who don't face racial discrimination. The same goes for food insecurity, housing instability, and lack of transportation. It is possible in the future that we will see that they will have significant tooth loss when compared to people who don't struggle with those factors. Next slide, please. The weaknesses of our study was that this was a cross-sectional study, which means that we can only discuss association, but not direct causation. Also, because this was a survey, there is possible inherent bias. So some participants, can recall things differently, they can report things differently, or due to the social desirability effect, they can answer the survey in a way that would be deemed more favorable. So reporting less tooth loss or things like that. And also, because social determinants of health are so highly correlated, we're unable to build one regression model to determine which determinant has the greatest impact on tooth loss. The strengths of the study is that since it was a nationally representative survey, it had a very large sample size. And also, our findings can help policymakers to focus their efforts on target populations that could really use the resources. Next slide, please. Recommendations for the future include working with and engaging with our local community, supporting local food drives to combat that food insecurity, just increasing the availability of healthy foods and drinks, working on food policies, and also creating more culturally diverse clinical settings to combat those feelings of discrimination. Next slide, please. In conclusion, out of the 6 social determinants of health, food insecurity has the highest odds of having at least one tooth extracted due to caries or gum disease. Also, social determinants of health, such as racial discrimination and lifestyle discrimination, are clearly having impacts on the oral health of those in our community, and it is our job as future health professionals to work on combating the discrimination in our clinical settings. Also, further research needs to be conducted to improve how people access food, stable housing, transportation, and dental insurance. Next slide, please. I'd like to especially thank my mentor, Dr. Raghad Obidad, for really helping gear me in the right direction in this public health department over the summer. I would also like to thank the Texas Recruits and Retain program, Texas A&M College of Dentistry Public Health Department, Ms. Tristan Lovecamp, and a special thank you to the CareQuest Institute for Oral Health, especially Eric Tramby, Majuli Samtani, and Abigail Kelly for helping us with all the statistics in our study. Next slide, please. I'd also like to thank you all for attending today and listening to our presentations. And next slide, please. And these are my references. So thank you.
Thanks to all our speakers for such insightful presentations. We have limited time, so let's move on to our Q&A session. Kindly type in your comments or questions in chat, and please don't hesitate to reach out via email in case we are unable to get to your questions due to time constraints. I am now going to open it up to our first reactor, Dr. Simmons, for any additional thoughts or questions on Lauren's presentation.
Can you hear me okay?
Yes, we can.
Hi, yes,
Because I
can
didn't
hear
have
you.
control on, oh, there we go. I thought you did a very good job. Nicely stated, nicely presented. You seem very confident in your content, and you captured my attention, and which is important. And I thought that was very well presented. And that's a big part of getting your message across, is making sure that you're doing it in a way that doesn't turn people off. And yours was done very, very well. You look at this and you wonder what are all the. It's interesting that the food insecurity was the most common indicator of tooth loss. And I'm not sure how we're describing that exactly. That might be food deserts and difficult access to fresh foods and healthy alternatives. And so that's an extremely important aspect of that. And being able then to address that by offering healthy food alternatives would go a long way toward at least addressing that aspect, that variant, or that variable in terms of tooth loss. So very well done. Thank you.
Thank you so much.
Good information.
Wonderful. Ms. Benton, do you have any additional thoughts or comments for Reem's presentation?
No, I think she was excellent also. She made very good points that the transportation issues have been around for years, and many health clinics also all areas, and she picked some wonderful points. Even when the best well thought out plans are in place, they still aren't successful. And so it affects the patient struggle with access as well as no-show rates and downtime in patients in the clinics. So she made some really good comments at the end of your last slide, some thoughts that you had maybe that would be beneficial to this could be a little bit successful. So what do you think your thoughts are at this point, briefly, that you think, just doing your research, that would be a beneficial, other than just getting funding from individuals? What would your thoughts would be?
In order to have more transportation?
Mm-hmm.
That's a really good question. And it's something I've been thinking about a lot. And I think, like you said, funding is important, but I think also maybe but making out a layout of certain systems. For instance, the DART system here in Dallas doesn't go to every location, when it kind of can just go like 5 more minutes and then it's at an FQHC. So I think just by understanding the locations of the buses or trains in the FQHCs may also help us with just spreading out.
That's a really good answer. That's true. I agree with you. And waivers, sometimes in the past, I've heard waivers, helping patients get waivers for transportation, maybe varied hours of operation for the clinics. But I think you hit on the really key of spreading out and finding different areas that would be beneficial. But so you did excellent.
Thank you so much.
Wonderful. Moving on to Dr. Burdett, do you have any more comments, questions, or any additional thoughts or insights for Michaela's presentation?
Yes. Hi, Michaela. You did a wonderful job. I was just so impressed with the amount of information. I do believe that you did it, just excellent as well. I like the fact that you seem confident, upbeat, your material very well. Your slides were clear. You were clear. So great communication and things like that. One of the things also that drew me to your topic was the fact of dental fears, because I work not only with adults who have aggressive needs, but also with children. So I was looking to learn some things, and I actually did. One of the things I thought about was like group therapy. I was like, wow, online, and I would think that people might be afraid to, to say something, but I thought that was interesting. One question I do have is that you listed, I think, 3 or 4 things at the end that are possible ways that you could take this research in the future. You talked about genetics, COVID-19, and finances, and then there was one other thing. If you had a choice, which one of those would you pick, and why?
I would definitely want to study the COVID-19 pandemic, because I feel like that has so many factors that comes into play with it, from infection control. So like dealing with how COVID-19 is a respiratory disease, but also the fear from contracting not only COVID from visiting the dentist, but looking to see an emotional aspect of it, because I know that maybe it might kind of counter dental fear, because last year I worked at an orthodontic office and people were actually happy to come see us because they hadn't had like social interaction because of the pandemic. So kind of looking at fear because they're scared to get COVID-19. It's a respiratory disease. We're working in the mouth, but also was it offset because they were excited to come and get social interaction? So I think that would be something that would be really cool to look into, especially since I don't know if there's a lot of research looking at the social aspect of people being excited to go because they're interacting with their dentist and the staff.
That's a good answer. I was thinking the other day I was in the office and a family hadn't been in to see us since 2019. And I thought, oh, it's so good to see you all again. And they go, we missed you all. And they were, like you said, they were excited to come back, but they were hesitant because it was COVID-19 and that was keeping them away. But one thing that I think we do well as dentists is that with our N95s and our PPEs, that we have done a wonderful job, and that should help patients, and parents feel safe. Thank you so much. I really enjoyed
Absolutely. Thank you for your question.
Mm-hmm.
It's so wonderful to see all the students confidently answer all questions. So this is truly amazing. Moving on, Dr. Vasey, do you have any additional questions for Asma's presentation?
Greetings, Asma. Can you hear me okay?
Yes,
Excellent.
I can. Hi.
So you also did a great job. I noticed there were a couple of small technical glitches going on in the background, but you were cool under fire and didn't let it affect you, professionally and clearly delivered. So very good job. My question
Thank
is, we stated the objective in kind of a two-part. It was the impact of the pandemic on dental burnout and how that burnout affects social determinants of health. And we talked a fair amount about the impact of the pandemic on burnout. Do you have any further thoughts on how that ends up potentially manifesting as an affectation towards social determinants of health?
Yes, so your question is just how it manifests more in the effect that it'll have on the patients.
Right.
Okay, so I think the biggest takeaway, especially in terms of social determinants of public health, was that we found that rural dentists had an increase in burnout as opposed to more suburban and urban dentists. And already those that do live in cities that are in a higher SES, more educated, they already do have an increased access to healthcare, increased quality of care. So I feel like those that are in these rural environments are just at an increased disadvantage now with their dental providers facing an increase in burnout, which just further decreases the quality of care that they're receiving. So I think that would be the biggest takeaway, is what populations are hit the hardest. Does that answer
I
your
think
question?
this is a great topic and one that we as an educational dental institution should maybe address in some way. The whole concept of dental burnout in general. It's something that my colleagues and I visit about with some frequency. So thank you for putting it out there for us today.
Definitely. Yes, thank you.
Thank you so much. Lauren, we have a question for you in chat, but I think we're almost at time. I think we have 2 more minutes. So if you could quickly address a question. We have a question for your presentation. Did you have complete responses for all social determinants studied? And what variables did you control for? And were a similar set of variables, control variables used for all the different multivariable analysis? Lauren, do we have you? I can actually answer that question quick. We did have almost complete responses, less than 5% missing on all the social determinants of health. And we controlled for age, race, all the demographics. I think we also controlled for income, education, and comorbidities for all of those multivariable models. And yes, we use the same set of variables across all the multivariable models. All right, we have a minute. Any additionally amazing? Thank you all the speakers, and this was great.
And thank you, Modalities and Tani. You were a marvelous facilitator. Thank you so much. And I would also like to thank all of our reactors and especially our presenters. You all did a marvelous job. Thank you all again for joining us today. We really appreciate you sharing your time, and many thanks to the Texas A&M College of Dentistry. Great presentation. You all have a wonderful afternoon.